Okay, so welcome to Tuesday's Journal Club. I will be giving a talk on a paper I read about excluding clinically significant bacteremia in the pediatric population. I have my academic advisor for this paper is Dr. Nguyen, and we have no any disclosures on healthcare goods, anything like that. All right, so what are the objectives for this talk? The objectives will be practice formulating specific clinical questions, using that to help understand this paper, starting with the PICO format, trying to appraise the article and understand its uses and limitations, to distinguish important factors in the determination the validity of the study, and to figure out how to apply it and maybe consider potential future studies. So basically, what is bacteremia? Why do we care about this article? Why was it written? So bacteremia is obviously the presence of bacteria in the blood, and we determine this through blood cultures. And we get these blood cultures for a large variety of reasons, including but not limited to isolated fevers, suspected meningitis, sepsis, if there's an indwelling catheter, and fever and neutropenia. But then we get these blood cultures. We start antibiotics, hopefully prior to the blood cultures being drawn, and then we have to think about when to stop those. So this is just a picture of bacteremia with gram-positive cocci. But looking at it, you have those blood cultures. How long do you give it to grow before you can call it not bacteremia? What are the statistics? Classical training would show 48 hours. But let's talk about this paper and what it found. And so we have that bacteremia, and if we're going to design a study to look at bacteremia in blood cultures, let's start with initial audience participation and design a study using this PICO format, which Lily covered in her last journal club, in which I'll give a brief overview as we ask each one. And so if we're designing a study to look at blood cultures, what population do you want to use? And you can chat in or talk in, and I'll give it, 20 seconds a question and then answer and move on. Perfect. So the population we're looking at is going to be pediatric. If we were designing this study, we'd be looking at the pediatric patients under 18 who had blood cultures drawn. And so the main intervention here is going to be that blood culture. But what would we compare it to? What's our control? So we could compare the blood cultures being drawn to healthy kids, but in the sense of this paper, we're looking at blood cultures and trying to figure out how long we give it. We'd be looking to compare control to timing. And Dr. Keyes raises an excellent point. If we're looking at blood cultures for timing, discontinuing antibiotics, what kind of patients do we want? And so overall, this would be well appearing. Well appearing without comorbidities. Thank you, Dr. Miller. And if we're designing a study, we're looking for outcome. The outcome is going to be, when do those cultures become positive? And so how long do we take data from? When do we look for it? And this one's more not an exact number, it's more of an intuitive based on information question. And so how long are we looking for data? Well, we want as long a time period as we can within our population. So whatever time period we have, consistent sampling methods, consistent analysis methods, and the type of question here is going to be looking for that diagnosis. And ideally, would this be what kind of study is it? Randomized control, cohort, case series, retrospective, etc. And so because we're looking at a time period, we'd be looking at a retrospective study. So let's see what this study was. Population, this study looked at those who had cultures drawn under 16, otherwise well appearing. The intervention was monitoring those blood cultures, comparing the time to positive results at different time intervals. The outcome was when those cultures became positive. It analyzed over an 8-year period from 2009 to 2017, trying to diagnose bacteremia, and then it was a single center retrospective study. So when analyzing papers, one of the things we look at is the who. So who wrote it and where was it published? So this was published in the Pediatric Infectious Disease Journal, which is a monthly peer-reviewed medical journal established in 1982. That was taken directly from their website. And it was done in Portsmouth Hospital at the NHS in England. So the authors were Anastasia Theodosu, who is an academic clinical fellow, so presumably well-educated, with her previous publications being in embryo research and pathogenic bacterial infections, and she's received multiple awards for infectious disease. It was also co-authored by a clinical librarian who had published other results in bacteremia, and a microbiologist as a consultant who was educated to the level of master's. And so our authors, reputable, our journal is from a reputable source. And so continuing in our analysis of what this paper is, why was this study done? So blood cultures are essential when you're managing febrile children in the duration of treatment, hospital stay, etc., and they help guide our antibiotic regimen. If blood cultures come back negative and a patient is otherwise well appearing, we can consider shorter hospitalization times and different utilization of resources. And so that's been known, but what has anything changed since some of these protocols were established? And so I'll talk a little bit about when the paper pulled its guidelines from, but some of the specifics that might have changed in the past since the 48-hour guideline was established. It would be different vaccination rates and how we monitor those blood cultures. So instead of having a person going around and taking a look at them, we have a continuous monitoring system, and vaccination rates, which have changed just since the late 90s, thousands in England and the US, and I'm including England because of where this population is done. And Verigene, thank you, Dr. Miller, which has been an excellent addition. Different vaccination tweaking, adding combination vaccines, different polysaccharide versus conjugate for pneumococcal, adding different serogroups to meningococcal. All these changes have been done in the past 20 years. And so the authors of this paper considered it time to take another look. And so the references, they referenced guidelines done in the US, which are from the American College of Emergency Physicians, and the Annals of Emergency Medicine. And we're just general guidelines of when to draw cultures, and then the UK guidelines as well, which are freely published and available to reference if anyone's looking for clinical pathways in different countries. And it pulled these data and looking for different changes, and based on these changes, looking at the idea of reanalyzing the data. So what's been done already? And so basic literature search for these things showed that some stuff has already been done in the neonatal period. 2014, JAMA Pediatric published an article in patients under 90 days. 91% of cultures were positive by 24 hours, and 96 were positive by 36 hours. And then other papers have looked at specific bacteria like pneumococcal or staph A. So a paper published in 2019 demonstrate that for pediatric bacteremia, the average time to growth was 17 hours. And so you have these specific journals for specific pathogens and neonatal period, but not so much for the general pediatric population. Okay, so that's the why. We talked about the who, we talked about the why, so let's talk a little bit about the where. The where is important when you're looking at journal articles because you need to be able to compare it to your own patient population, wherever you're working, whoever you're working with. And so this was done in England, at Portsmouth. The 53,000 blood cultures were obtained from patients under 16 years old. A third of them were from neonates, 20% were from 1 to 12 months, and the remaining were from those older than 12 months. And so they obtained demographic data for all of those patients with additional comorbidities for any which had positive blood culture after 24 hours. And then they compared all that with their own database searches. And so, like I said, comparing this journal and who they looked at to what we have in this area, if we're going to look at a journal to apply to our own patient population. So Portsmouth, England is a population of 200,000. The majority are white, of white descent, 88%, 6% Asian, 2% Black. Primary industries are going to be the naval dockyard and IBM headquarters. There are multiple universities. But the big thing to look at for us is going to be that pediatric population. For the English vaccination schedule, 90% of this population are reported as fully vaccinated. 25% live in poverty, 25% are obese, and 2% have teenage pregnancies. So I tried to pull similar data and information for Carilion. Carilion expands over most of Southwest Virginia, so it's harder to pull specific facts. So the ones I've listed here are mostly for just Roanoke, and our population is around 100,000 people, 70% white descent, 26 Black, 1% Asian. The main industries here are, as you're all aware, Carilion, railroad, and then Advanced Auto Parts headquarters is located here, which was kind of a surprise to me. But then we have nearby colleges and universities. And we don't have specific vaccination rates for Roanoke or Southwest Virginia, but just Virginia as a whole. And in 2018, it was reported that 82 to 85% of school-age children were fully vaccinated. And so the other thing we need to look at to compare to this study is how do we do blood cultures and how did they draw blood cultures? So I called our lab to ask them and made them very nervous because apparently when you call to ask, they assumed they were getting audited. I immediately got transferred to a supervisor who was incredibly helpful. And I did my best to assure her that I was just an innocent resident, but I'm not sure how much she believed me. So we have an aseptic collection technique with varying blood volumes. Roanoke is the only hospital in the Carilion Health System that has a microbiology lab. So if you draw a culture at any of the other facilities, those get sent here. So there's always going to be a delay from drawing time to machine loading time if it's not drawn in Roanoke. The machine itself looks at carbon dioxide changes and color changes every 10 minutes. And if you open the drawer at the wrong time, it may trigger false positive. So if Epic ever pops up and says, you have a positive result, but an organism we're seeing, that's likely a false positive caused by someone opening the drawer. And then once you get a positive result here, it's immediately gram stained. Verigene is run, as Dr. Meier pointed out a little bit earlier, which can help narrow it down, decrease identification time. And then we can run PCR for certain anaerobes. Once it's identified, they run it for sensitivities, and that takes 18 hours from time of identification. And according to the nice person I spoke with in the lab, that's done immediately after they get that positive result. Okay, so that was the where. Now let's talk about the when. So it drew blood cultures from 2009 to 2017. And this paper itself was published September of 2019, so 1 year ago. We already talked about the age ranges for which blood cultures were drawn. It uses a semi-automated continuous monitoring system. I imagine similar to the one we use here with at that 10-minute interval. And then it's integrated in the hospital management system, which again, I likened to our using Epic. And from that, they calculate the time to positivity. Okay, so that's the win. How did they do this analysis? So they did a retrospective analysis. They did which is for the medical students, an observational study that enrolls participants who already have disease or condition. And so they defined their population timeline outcome in their data search and their database comparison. And they used the terms blood culture, sepsis, bacteremia, septicemia, time duration, time positivity, time to detection. And then their specific age ranges, they needed to use a couple different phrases to get all of the groups they were looking for. Infant 1 year, or unspecified child, or preschool child 1 to 6 years, or 7 to 12, or adolescent 13 to 16. From that, they recorded the time of collection, which they inferred from when the blood culture was ordered, the loading time, and the time the culture itself was identified as positive. And like I said before, they collected comorbidity information for all positive cultures. Further in the how, they defined the pathogens and the positive and negative results a different way. So they took 15 organisms which are known to cause clinically significant bacteremia in previously healthy children and compared it to all these others which they considered contaminating or opportunistic. The ones that are known they called definitive, and the others they called contaminating. And risk factors for contaminating or opportunistic would include things like immunosuppression or those indwelling catheters, which, as everyone pointed out a little while ago, we're looking at healthy kids, previously healthy kids, not complex or those with indwelling lines. Okay, that's that part of the how. And the next part that's important when analyzing a journal is to see how they do their statistics. So let's talk for a second about pretest probability. So blood cultures themselves, do they have a high pretest probability of being positive? So yes, Dr. Keys, patients with lines were excluded. And so we're looking at that pretest probability, positive results out of 53,000 cultures, which is about 2.5%. So if you're just looking at pretest probability of a positive blood culture, it's only about 2%. But we also use that negative culture result to change therapy. So you can't just look at pretest probability of positive blood cultures to kind of put it in one box. It's more of a big picture kind of thing. And so talking a little bit more about statistics. So for the medical students who have not taken step 2 or level 2, or for those who are planning to take level 3, we can talk a little bit about positive predictive value, negative predictive value. And this is just a example problem as well to kind of drill what those are and kind of drill that home. And so a positive predictive value is going to be the percent of people with positive test and to have the disease, and then negative predictive value is going to be negative test and are free of the disease. And so let's assume we have a test with 100% sensitivity, which would be fantastic. It picks up every possible potential case. But if there's a false positive rate in those tests of just 5%, we can start filling out our box there, our statistic box. And so false positive rate 5%, so we have true negatives for 100% sensitive test of 95 over 100. So our test has a sensitivity has a specificity of 95%. So in the real world, if we have this imaginary test and we get one positive result in 1,000 people, and you have you have that 5% false positive rate, and so overall that means 50 people that you test out of those 1,000 have a false positive. So you'll end up with 51 positive tests and one of those being true. So if you get a positive test running this imaginary test to look at the PPV or NPV, you get a positive result. There's still only a 2% chance that positive test means they have that disease because you have those false positives. So if you think about that and try to apply that to our blood cultures, you have a negative blood culture at 24 hours. What's the percent chance that that blood culture remains negative at 36, at 48? And so we'll kind of circle back to that specific problem in a little bit, but that is just a good way to kind of look at those results. And if you're taking step 2 or level 2, step 3 or level 3, being able to create this box, you can pretty much put any stats question into this box and work your way forwards or backwards to solve that. Okay, and the other thing to talk about is taking something that the paper does and being able to analyze it as well. And so they did a bunch of different data analysis with a lot of fancy names, like Amand, Whitney, Mantell, Cox, logarithmic ranking. But one of the things that they showed is this Kaplan-Meier test curve. And so a Kaplan-Meier curve is a survival curve. The word survival is kind of a misnomer in the sense that we're using it. It's really just an endpoint. When did things start? What is the end point for those things? And so for us, we consider a time to positive culture as that endpoint. And so once it's positive, we're moving up. And you can see our data from the paper on the right. The general concepts, which are illustrated by the example in the middle. If you see those step-offs, if you're looking at a Kaplan-Meier curve, the more steps, the higher number of subjects. So a low population, like in the example one in the middle, shows a lower population volume, so it kind of looks like stairs. If you lose anyone while using a Kaplan-Meier curve in terms of loss to follow-up, your graph is no longer it is now considered an estimate of that population. And obviously, the more you censor that population, less reliable those results are. And then there's, of course, a kind of a survival bias. If you have a large population early on with a higher survival rate, it might give the impression that events happen at different rates. And so that's kind of big picture what a Kaplan-Meier is. And if you look at our data on the right, which I'll again circle back to in a couple slides, it shows that the red shows you the positive definitive pathogens, with the green demonstrating the opportunistic. And it shows that variation in time to positivity based on the survival curve. The one below it separates neonates compared to other cultures, which show that they were very similar in result time. And so more specifically, our results, they obtained almost 53,000 cultures, 1,300 were positive from 989 patients. And so, as you can see, multiple patients had multiple blood cultures drawn. Of the definitive pathogens, there were 25%, and it demonstrated that definitive pathogens grew at a faster rate, which you saw on the slide above, in 12.5 hours. And the opportunistic, which comprised of the majority of D positive, grew at 22 hours. So an earlier blood culture is going to be more likely associated with those definitive pathogens, even if you don't have the speciation back yet. The paper also wanted to make clear and point out that 27 cultures grew after those 24 hours. Of those 27 cultures, 24 of them were not eligible for discharge. And so the outcome for them would not have changed. The other 3, 2 of them had been discharged on antibiotics already and did not meet hospital admission criteria. So it would not have changed their management. And one was already on antibiotics when cultures were obtained. So it's a little unclear how that might have progressed, but might have pointed to why the culture grew so late. Other results include the neonate versus non-neonate. And back to that Kaplan-Meier curve, it showed the time to positivity of neonates versus the rest of the population. And they're virtually identical. So based from this and previous studies showed that neonates significant bacteremia could be excluded closer to 36 hours. We might be able to infer that something similar might happen in the older population. And then one of the other things that they noted during this study is that when blood cultures were collected at night, the time to be loaded in the machine actually took a lot longer. So there was a significant delay overnight. And so something to think about when obtaining blood cultures is where do they come from and how long did they sit kind of in stasis until they get loaded into the incubator. And so that's all of our stuff. And so how do we analyze that? We can circle back to look at that negative predictive value from before and start plugging numbers into our chart. So that negative predictive value is going to be the chance that a negative value is a true negative and the patient does not have bacteremia. And so our numbers here, positive blood cultures around 306 at this hour mark of definitive pathogens with 27 negative cultures at 24 hours. So plugging those numbers into our equation, which you can see in the left chart, negative predictive value is going to be those true negatives over true negative and false negatives. And so that ends up being almost as 99.95%, which seems very high and definitely is a pretty good negative predictive value. However, you still have to think about prevalence. So how prevalent bacteremia itself actually is and how prevalent those positive blood cultures will be can definitely skew your results. So if someone wants to throw in the chat, if you have a higher prevalence, how does the negative predictive value change? So you have a lot more positive blood cultures, or a lot more bacteremia. How would that change our numbers here in the negative predictive value? Would it go up, down? If it's a lot higher in terms of prevalence, does it go up by a lot? Does it go down by a lot? Perfect. So as that incidence prevalence would increase, the positive predictive value would increase, but negative predictive value would decrease. Perfect, Dr. Ames. And you can pretty much just plug in numbers, put in arrows into that equation and to verify that if that's true or not. And so did the paper accomplish what it was looking out for? Does it point one or the other? If you can take a look at blood cultures in well-appearing children and say at 24 hours, if the culture is still negative, does that mean they don't have bacteremia? Can we think about discharge shortening hospital course, shortening antibiotic course? And so to think about if it accomplished what I was looking out for, the next thing to think about would be what issues came up. What are the potential complications? What did they not account for? What might play into how you think about these things? And so just chat or unmute and mention it, and then I'll talk about the potential issues that I noted in the next slide. Perfect, Dr. Nguyen. And yeah, they were not able to determine if antibiotics were given prior to when those blood cultures were being drawn. Anyone else? Give you guys another few seconds, then we'll keep moving. All right, so let's talk about some of the things I noticed that might have skewed their data, or things that should be thought about for future studies. And so the first one is going to be that this was a single center study. They obtained an impressive number of blood cultures for their size, but they were just in one specific area and one specific population. In the positive culture group, they obtained a good number of positive blood cultures, but in terms of trying to figure out what effect that is and how you can apply that to a broader population, did they obtain enough? Certain infections and certain bacteremia might have a low enough incidence that 50,000 cultures might not have been enough to capture those in their population. They obtain multiple cultures from the same patient, which skews data one or the other if the patient is already going to develop bacteremia or not. In terms of the blood culture result, needs to be compared to other institutions. So how blood cultures are collected, what the sampling volume is, what the contamination rate is, what the vaccination rates are of different areas. So can you apply this more universally? Do they need, again, a multi-center study might have helped with that data collection. One of the things that I noted while doing research for this journal is that blood volume plays a very large role in how much or how quickly some of these samples might develop. And there wasn't data here included here that talked about how much blood was obtained from each patient and what they based those volumes or draws on. And then the other variable is the time to loading in the machine itself. Dr. Keys, determining if it's safe to discharge someone, yes, would have been the not necessarily the goal, but something to point in terms of hospitalization management. If we're trying to shave off the time this patients are on antibiotics, how long they're in the hospital for, et cetera. And your point about not giving enough information yet plays very well into my next slide, which is, so what? How do we take what we learned from this journal? Did the journal meet its goals? Was the study valid? How do we implement it to our own patient population in terms of well-appearing febrile children with whom blood cultures were drawn? And yes, the difference between well-appearing and then complex patients with comorbidities or lines, neutropenia, et cetera. And so let's talk about the validity of the study first. Do a little guided talking. So was this study valid? Did it have internal validity? And some of the things to think about in terms of internal validity are listed there. And so if someone wants to chat yes or no in terms of, do you think it is an internally valid study? Perfect, I would agree. They internally valid, they had a large sample size. They were looking at similar group, the same age population. It was well-appearing children who had blood cultures drawn, who might febrile, well-appearing children. They didn't lose any blood cultures to follow up in this case, and the results themselves were objectively measured. Some of the things that might threaten internal validity, if you're looking at other retrospective studies, would be comparison issues, untracked interventions, Hawthorne effect, which again, those taking step 2 might remember, which would be that where you report in a different way because you're aware of the study going on. But in terms of drawing blood cultures and tracking their time to positivity, I believe most of those weren't a factor in this retrospective study. And then can we apply it? Does it have external validity? Does our population the same as the study's population? Is it feasible to take a look at otherwise well-appearing febrile children in the pediatric population and think about shortening that antibiotic time, think about shortening that hospitalization time? And then the other thing to think about in terms of this external validity is what's potential harm if we start trying to take those measures. And so to kind of include more bigger picture stuff, feel free to chime in or talk about if you believe this study is applicable to our population based on who was studied, at what age ranges, its vaccination rates, what your current clinical practice is when you see a otherwise well-appearing febrile child in terms of how long you wait for those blood cultures to result and how long you keep them hospitalized for. And if the study itself changed your mind in terms of applying it to your own practice.
Good job, Kevin. I mean, I think that it is relatively similar population-wise. The problem is, like Dr. Keys pointed out, where, they're talking about shaving off hours off of our current practice, and just the practicality of, like, would that really change our day-to-day medical management? I mean, maybe if we're right at that couple hour cutoff and it's evening time and they're about ready to go. But other than that, I don't know that it really changes our current practice paradigm.
That is a good point again, and it looks beautiful where you're watching lectures. And so do those few hours make a difference in terms of discharging patients, keeping them on antibiotics, in terms of applying the study to that? It's hard to say. It also might be dependent on what time of day you get those results. So if you still have a negative blood culture and someone wants to go home at 36 hours, does that change what you're thinking about? Does that change if you're willing to agree to let them go home? And with missing that culture results, what kind of follow-up do they have? So it's never going to be a black and white answer. But in terms of taking that data and thinking about how long these patients need to be on these antibiotics, if there's what potential harm from being on certain antibiotics for those 48 hours, just in general, using this paper or other papers like it to kind of shape your clinical acumen. And Dr. Nguyen, for those who don't have the chat open, is asking what everyone else's current practice is, waiting 36, 48 hours for negative culture results, and if this changes for them in neonates versus older children.
It might be easier for me to chat. For me, maybe I'm a little bit more old-fashioned, but I think I typically use 48 hours for neonates, but then I also kind of weigh, were they ill-appearing? Is there anything fishy about the story that makes me think there's a higher pretest probability for bacteremia? And then kind of weighing, well, where does the 36 hours or where does that 48 hours bring me? Does that cost them another stay overnight or not? And having that conversation. I think you're never going to reach 100%, even as you extend the Kaplan-Meier curve with the longer time of monitoring blood cultures. So I think the key, which Andrew Miller mentioned, is at what point are you willing to risk that 1% or a few percent of missed positive blood cultures?
I think Dr. Nguyen, her point is excellent. And one of the things that Dr. Keys brought up recently with a patient we had with blood cultures that I thought was helpful is, Kevin, like you mentioned, in Southwest Virginia, our patient population is spread broadly. And so how long is it going to take this person to get back to care? You know, if this person is way out on the West Virginia line, that might really influence my decision even more so than, you know, if they live in Southeast Roanoke.
Excellent points all around. And then Dr. T's point of why would a well-appearing child be in the hospital in the first place? That is, there are too many variables for me to speak on that one way or the other. But if a well-appearing child does appear in the hospital, is hospitalized, or is well-appearing by that 24, 36-hour mark when they weren't on admission, that might, again, change your analysis of what's going on. And then the indwelling line would be that higher risk factor, that comorbidity, and they didn't speak on it too much, no, Dr. Miller. In terms of, for Dr. Miller's question, in terms of what about the well-appearing child with indwelling line that we got blood cultures on, the comorbidity, the risk factor of having that indwelling line personally would raise my index of suspicion higher, and I don't believe I would trust a blood culture at 24-hour yet, just because of that additional risk factor of comorbidity.